Hello and welcome to the Auditing Antics podcast. So today we're going to be finishing out our Mental Health Awareness Month with some Q&A. And, overall, I hope, Michele, this month with us going through and sharing, things about us, things that we've been going through with friends and family, apart from the medical coding and billing side of things. I hope that somebody has heard this and it's helped them in some way, because I know that can be difficult.
Yeah, I agree.
All right, so let's go ahead and get started. Michelle's going to be our lovely moderator for the day. So go ahead and start with those questions, Michele.
All right. So question 1 says, if the provider billed an E&M with psychotherapy, where in the documentation am I supposed to see clearly see the separation between the E&M work and the psychotherapy work?
Okay, so good question. And this is something we get asked, or we see in audit work quite a bit. I do get asked this quite a bit
I
by
see it
providers.
incorrect all the time. Very
Yeah.
rarely do I see it documented correctly.
Yeah. So it's always my recommendation that we can see somewhere that the psychotherapy has its own distinct area. But in order to correct this, if it's very cloudy and not clear in the note, I will say you need to have a conversation with your providers, because a lot of times from the clinical perspective, they think that they're covering a lot of it in their HPI, but we have to have that HPI separated from discussions related to psychotherapy. If you listen to the last, I think it was the last episode, no, the one before, 2 episodes ago, we talked about how there is, a difference in workflow on the clinical side where they're essentially doing a lot of this collectively together, but then for coding, we need to see it separated out. So have that conversation internally to clarify some of those areas that are confusing, and then talk to them. I prefer to see it in the bottom of the notes. So maybe finish out everything for the E&M, the prescription management, have separation so there's space, and then a new paragraph with the psychotherapy. And remember, everything for therapy still has to be there. So the time, the modality, the discussion, all of those things still have to be there. We just want it separated out so it's very clear to an external auditor.
Yeah, and I also just want to point out that it would not be acceptable to copy your HPI from your E&M and paste it into a separate note for psychotherapy. It truly needs to be its own separate documentation.
Okay. Yep.
Because I feel like that's I just feel like that's something I would see done. I don't know. Maybe my recent audits have. I mean, do we ever have faith in copy and paste?
Yeah, no, it's true. It definitely could happen for sure.
Yeah. Okay, so question number 2. What am I supposed to code when the psychotherapy note documents patient conversation, but no actual therapeutic interventions?
Yeah. So again, this is kind of piggybacks on that first question where, yes, we need the documentation separated out and we still need everything supported. And, I have seen this sometimes. I'll see something that says psychotherapy time, 25 minutes, discuss family issues or work issues or something. And we have little to no information. And yes, we still have to have the different techniques, the modalities. All of that still has to be in there, because remember, at a base level, when we look at the CPT codes for therapy, that is what it's representing. In the same way that we can't have someone just say a procedure is performed and bill a procedure, we need the detail. It's the same thing when it comes to therapy. It's not enough to just say they've discussed in their therapy time. We have to know what they are doing in order to make sure that it's supported under the CPT code.
Here's something that I just thought of, a question that kind of goes along with this. So what happens when you're auditing or coding psychotherapy and you see the patient interaction, and then it's always the same statement. You can tell it's like a smart text that they've put in saying the same therapy techniques have been used each time. Like I see a lot like, utilized CBT, integrative therapy, things like that.
Mhm.
Oftentimes it looks the same from
Mhm.
patient to patient for some providers. So, what are your thoughts on that? Would it be expected that all therapy techniques be used for each patient? Is
It's
it
going to be similar. So
okay?
that part actually doesn't concern me because
Okay.
there's so many ways to identify a technique.
Yeah.
So maybe that particular therapist has something that they focus on, and that's the main way that they handle their therapy sessions. If that's the case, that's not concerning to me. One thing I will say though is when it's documented that way, it is very important that we have it individualized regarding the discussion.
Yeah.
So the discussion can't also be the same every single time, along with, like I was saying, we shouldn't see generic things like discussing work issues, home issues.
Yeah.
It is up to the practitioner to determine, especially if there's sensitive information, what they want to put in there. But we need enough so that it's still individualized or medical necessity is going to be questioned.
Okay. So, question number 3. If the rendering provider is listed on the claim, oh wait, let me start that over. I'm having issues today, apparently. Reading. If the rendering provider listed on the claim is different from the person documented in the note, who actually performed the service? Am I okay to go forward with submitting the claim this way?
Okay, so in general, that wording is a little confusing, but in general, when we think about who is billing the claim, we actually have to look to the question of what is their licensure? What do the payers look at from an enrollment and credentialing perspective? And are they expected to enroll this provider as a part of the practice? Or, with some of the counselors, for example, or if you do ABA therapy, the technicians, they're not required to be enrolled and credentialed for the most part with a lot of the payers. The expectation is that they will bill under the supervising, but they also will meet all of the incident to requirements.
Okay.
So that's kind of a loaded question and a loaded answer because
Sounds
it's
good.
going to depend on a lot of the variables. So when I am asked this question, the first thing that I'm going to say is you need to bill under the person who actually performed the service, but then you also have to make sure that they're credentialed. So if it's and adding in one other thing here that gets very messy within behavioral health, especially with psychotherapy, we have situations where some of the clinicians are going through the process after their graduate program to obtain the required clinical hours to be eligible to test for their license. So in that case, when they're waiting for licensure, that also depends on payer policy because some of the Blue Cross Blue Shield plans, for example, say that they allow a graduate to do that and they'll pay under the supervising. And there's certain modifiers that you use to identify that. Other ones, it's a no-go. You can't bill for them at all. They have to be self-pay.
Yeah.
So when you see a difference between the person rendering and the person billing in behavioral health, you actually have to dig in deeper because that could be a workflow issue. It could be a lot of other things that are happening. But that's the answer. You got to do more research. It's not straightforward. It's going to depend on the
Yeah.
payer.
Yeah. I always hate it when that's the answer.
I know it's not black and white in that one.
Rarely is it ever, let me just say. Rarely is it ever. Okay, so number 4, my practice has the expectation that all encounters will be billed within 24 to 48 hours after the encounter, but there are multiple providers who are always late on finishing their notes. How am I expected to code these services accurately when the documentation is signed days or weeks after the encounter?
Okay, so again, a huge break in workflow process. That's a big compliance issue. So when I have a client, and especially if I'm working with them for the first time, I will ask questions about, what do your billing patterns look like, especially if they have situations where they don't have dedicated coders. If we have an AR process that has, them submitting everything within 24 to 48 hours, well, sometimes, the group is on top of it. Providers are really good, but we know in some way, typically, there's at least one or a certain number of providers that are late on documenting. So, with this, you actually have to approach the process of your submission because that is where there's a problem. You
Mhm.
cannot just select something prior to a note being done, and prior to that, it really needs to be authenticated and signed as well. So you won't know, you can't guess, you have to wait.
Yeah.
So if that is something that the practice has an issue with, that needs to be something that's handled at more of an administrative level because now you have an issue occurring with one of the providers. And that's not for a coder or a biller to deal
Yeah.
with. um, don't push claims out, don't guess, but it's not your place all most of the time to go and try to fix that. But you do
No.
need to bring awareness to the situation, be a part of the conversations, be a part of the solution with workflow. But the answer to that is that you can't know what to bill, and you shouldn't be billing if that is the setup.
Yeah, it's kind of interesting because how that is worded, it sounds like the coders are being held to that expectation, but the providers are not. And that is completely backwards. That is not a coder issue at
Yep.
all. And that's just kind of interesting. But in all honesty, I have worked in environments with that kind of logic, and they will not be told otherwise. So, yeah, you're not the problem.
Yeah.
That's all you need to know.
Yeah.
You
Yep.
cannot be expected to code
Yeah.
that accurately. So question number 5. I am struggling to support the coding for one of the providers in our practice due to a lack of detail in their notes. What supports billing add-on psychotherapy codes when the documentation barely supports the underlying E&M service itself?
Oh man. I
Yeah,
laugh, but these are things we see in our audits all the time.
yeah. I mean, I have done audits where the provider adds on that complexity code
Mhm.
every single time, and I'm reading, or they bill crisis, and I'm
Mhm.
reading and I'm like, I don't see crisis or complexity.
Yes. Yes, exactly. So, with something like this, there needs to be education, there needs to be communication. From the sounds of it, if you don't even barely have enough to support the E&M service, there first of all, do not add psychotherapy because you probably don't have that. And, not only do we have to think about the fact that these documentation patterns are going to affect what's going to happen in an external audit, for example. But this description of what the notes look like sounds like you definitely would be questioned from a medical necessity standpoint as well, because the question is going to be frequency. And depending on frequency, depending on how often they're seeing the patient, depending on what meds they're giving the patient, those types of things are going to have to be answered apart from the therapy question. And even broader than that, it helps to understand if within the practice the patient is also getting therapy from another practitioner in the group
Mhm.
or outside of the group. Because sometimes I find that where, I'll say to them, well, you want to add psychotherapy to every E&M service, but you also have an entire team of therapists that are working with the patient. So on this individual day, what was going on that you needed to help the patient through that? So it doesn't mean that it's wrong, but the only way that that can be validated and supported and defended is if we see that in documentation. So from the coding or auditing perspective, there's not really anything that you can do to support that with what you're working with from the sounds of it. It's more so going back, having conversations, again, follow the correct, communication chain within your organization. But that's going to have to be education before you can even think about moving forward to the next steps of what, needs to be in the note and how to code that.
Yeah, and another thing that I want to point out in situations like this that I am just recently learning and running into is also sometimes it is the provider not understanding how the EHR works. Sometimes after they finish their note, they're presented with all of these different possible codes that they can bill, and they're just selecting things. I've run into situations where the provider knows a coder is going to look at it. So every single time they select level 4 or every single time they select level 3 because they know a coder is going to look at it and take care of it. And when you go talk with them, you realize it's a workflow and not understanding the workflow, not so much the expectation of always billing psychotherapy with their E&M. It's just there, so they select it on their screen, and so that's also a possibility. So it makes that conversation even more important with the provider.
Yep, I agree.
So last question, I forgot for a second that I'm the one here reading the questions.
We're really on top of it today.
Are we sure it's not Monday?
Well, that's the problem. It's a holiday week and we're dragging.
Yes. And last week I had some kind of weird sinus thing going on. I don't know. My brain's just not with it. Okay, so question number 6. How can I accurately code this telehealth behavioral health services? Okay, that's a lot of health. If the note never specifies whether the visit was audio only or audio, video, or audio only. So if they don't specify, how can we code?
So, and I'm assuming in this, maybe they're talking about like psychotherapy. I can't remember in all the health words if it said therapy.
It didn't. It just said, how can I accurately code this telehealth behavioral health service?
Okay. So let's talk about therapy. And the reason I bring that up is our codes are going to stay the same, which for a lot of the payers now with E&M, the code is going to stay the same as well. Our place of service is going to stay the same. So it's really the modifier that's going to be different. And it is very important to have all of that documented because a couple of things. It could affect reimbursement. A lot of payers, especially for behavioral health, are not going to be making adjustments or saying that one is getting reimbursed less than another, but that is still a possibility depending on the payer, depending on the policies, all of those variables. But remember, it's not enough to just say telehealth. And, this makes me think about all the questions I get all of the time when providers want to bill video across the board, whether it's occurring or not. And they'll say things like, well, the patient wasn't able to, they tried and it didn't work, or we tried to get connected and it disconnected, or the provider was able to join on video on the HIPAA compliant platform, but the patient wasn't able to connect video. We have to have a full video encounter in order for that to be billed with, the 95, the GT modifier, whatever it is for that payer. So the majority of the encounter has to be conducted via video, and we need that supported in the documentation. And Michele, this makes me think about the fact that we still in 2026 are auditing telehealth records that have no telehealth statement.
Oh, absolutely. Or lack the amount of detail to know that we're doing the place of service correct. Like, in addition to audio, video, or audio only, you need to tell us where the patient was. That's just as important. Were they in their home or were they outside of their home? Were they in a different state? Because if that's the case, pump the brakes. You know what I
Yep.
mean? Like, there is so much that we need to know to properly bill that it's not even there.
Mm-hmm. Yep. Yeah. So
It's
again, it's another area where it's just not going to work. So
no.
you have to go back, you have to have a discussion. And, one theme through these questions that we got that I'm seeing is, well, really what you were saying a little bit ago, Michele, where it's interesting that people that are coding or auditing feel like it's something that they're responsible for. No, you have to go back. You can't work with nothing. If
Yeah.
it's not there in the note, then what are you going to do? You're not going to be able to code it. You're not going to be able to bill it. So you've got to have those conversations internally. And
Mhm.
if the providers aren't listening, if they don't want to change, their habits, their workflow, whatever it is, then you need to have administrative level conversations about that as well.
And I think one
Mm.
area for behavioral health in particular, especially psychotherapy services, that we see challenges for providers is their schedules are so packed full. So we have to try to be part of that team. If you're going to speak with that provider, listen to them. Don't just go there saying, I need this, I need this, I need this. Try to have some solutions. Go with the mindset that you have to work as a team to figure this out. It's not just the coder's responsibility, it's not just the provider's responsibility. We are a team that
Mhm.
needs to work together to get things right and get it out the door, within the company's requirements, 24 to
Yeah.
48 hours for this one person. Um,
Yeah.
I mean, some providers are right on top. They have their workflow down. They have, they have things set to a T in their system, their templates, their workflow, everything. But others, I mean, I'm sure you have been there, Stephanie, chasing down.
Mhm.
I remember having to wait outside the office of a locum hospitalist at 6 a.m.
Fun.
waiting for him to come back because we had notes from 3 months prior that he hadn't finished. Like, I'm sure we all have been in that situation where we've had to chase those providers down, but that shouldn't be the norm. It shouldn't be their
Mhm.
day-to-day billing.
Yeah, exactly. All right, well, that's the last of the questions we have. And, I was just thinking about something. So this is not going to be coding related, but, well, I guess it's semi coding related because it happened during May Mania. So I went to a local chapter meeting and got to meet a lot of people. I did a couple of sessions for the local chapter. And I've been thinking a lot about connections in the way that, it's one of those things, whether you believe it's a God thing, whether you believe it's a universe thing. To me, it's just very interesting how we're put into situations where we can help other people when we are willing to be open and have vulnerable discussions. And I want
Mhm.
to talk about this really quick as we finish out Mental Health Awareness Month, because I had an opportunity come about where someone was really struggling through a situation related to mental health within the family. And, it's really a hope of mine as we continue to use this platform, Michele, and as we're willing to be open that more people are going to have these discussions. But it came about that we were just talking, and they start to talk about some things that are happening that were really difficult. And they weren't necessarily mentioning it like being like, oh, give me advice, that type of thing.
Yeah.
But it opened up a door to have a conversation similar to what we've been talking about in the first episode this month of things we've been through, our cousin especially, which again, I have to say every time I'm so incredibly proud of her.
Me too.
But it opened up the door to have a conversation that ended up helping this person feel more relaxed in the situation because remember, there's still so many stigmas around it. And
Mm-hmm.
one thing that I noticed too is that as communities in general talk more about behavioral health, it still feels very overwhelming when you're going through it. You don't know who to talk about with it. I remember back when I was first going through some things with teenage daughters, I was just like, whoa, I don't even know how to handle this, what to think about it, what do I do, how do you parent through that, all of these crazy things. So by being open, by having conversations, it alleviated some of what the person was going through, but also led them to some other options related to treatment and things to explore in the area. So I just want to encourage people, get out there. It's not like we stop people on the road and say, like, hey, you
Let
look
me
like
tell
you're
you the
having a
good
bad
news,
day.
Axel.
Yes. But I want to encourage people to have the conversations.
Yeah.
Even if it feels awkward to you at first, there's always somebody who's going through that. And I saw a video yesterday on social media. I don't remember the actress's name. I'm really bad with names.
So am
But
I.
she had a situation where her child had a medical condition and it absolutely scared her. They were very lucky because they caught it early, but there's this window of time where you have to receive treatment. And she was telling the interviewer, I got it in my mind when we were going through this that I was never going to talk about this. It was going to be kept quiet. It's going to be a secret, all of these things. But then years later, she happened to mention something when she was speaking and doing a presentation. And someone came up to her afterwards and was like, thank you for so much for talking about this. We went through the same thing, but we didn't have awareness, so we didn't catch it within the window. And, our story essentially looks different than your outcome. And for her, it was like this light bulb moment. Like, why did I think that I needed to be quiet? Why did I think that, this isn't something worth discussing and getting awareness out there? So as we finish out May, just think about it. If you're struggling, have conversations. You don't have to, verbally vomit all over somebody to say, hey, I need help. But, start to have conversations. There's going to be people out there that are not open to it. And frankly, that's how over the past years I've decided who to let into my life on a more personal level. If there's people that, have a certain facade and want to do their thing like that, then they can go do that separate and elsewhere. But be open, think about it. Like I said, again, hopefully this month has really helped some people between the first episode and this little discussion here. And we're going to move forward next month and we're going to jump right into some things about AI, credentials, what we want to look at for advancing careers, things like that. And I hope everybody is doing well. And if not, reach out and ask for help in some way. Mm-hmm. All right. We will see you back next week. Have a good week.